Tuberculosis, or TB, is the leading cause of death in HIV-positive people, claiming over 300,000 lives in 2017. Globally, people living with HIV are 26 times more likely to develop tuberculosis than those that are HIV negative. Both sputum and urine-based tests are available for detecting tuberculosis. Urine-based testing, however, has more advantages over sputum-based because urine is easy to collect and store, and lacks the infection control risks associated with sputum collection. Also, HIV-positive patients tend to have a hard time producing enough saliva for sputum-based tests. Urine assays for the active TB marker lipoarabinomannan, LAM or LAM, are more practical and thus far only show sensitivity in patients co-infected with HIV, who may have a higher concentration of LAM in their urine. The WHO recommends the test only for people who are HIV positive, gravely ill, and have a fewer than 100 CD4 cell count. According to the preliminary analysis by the Clinton Health Access Initiative, the estimated need for the test is between 2.7 and 2.9 million people with the CD4 cutoff of 100 and 5.8 million with the CD4 cutoff of 200. Both the WHO and donor organizations such as PEPFAR, the President's Emergency Plan for AIDS Relief, should make greater efforts to producing and supplying more TB LAM tests globally for HIV-positive patients. This supports the bioethical principle of beneficence because providing more and cheaper options for diagnosing tuberculosis for those who have poor immune systems will allow for faster treatment and diagnosis. This also will lessen the chance of spreading the disease to others who have a low tolerance to fight tuberculosis. This supports the principle of non-maleficence because according to evidence from the WHO, the test correctly diagnoses tuberculosis in 56% of patients. So clearly this is not a perfect test, but there's literally zero harm in doing it, and it has saved a lot of lives. In a recent study published by the Science Translational Medicine journal, the test demonstrates a 95% sensitivity and 80% specificity in 48 HIV-negative hospitalized patients in Peru in a laboratory-confirmed active tuberculosis setting. With new nanotechnology and a high-affinity copper complex dye, they've been able to increase LAM detection from 100 to 1,000-fold in newer studies. So this will better diagnose patients with HIV. This also supports the bioethical principle of autonomy. Patients cannot make informed decisions without knowing their diagnosis of tuberculosis. A urine test is easy to administer and can provide villages with even a few health workers the ability to diagnose and thus quickly treat their citizens on their own. Lastly, this supports the principle of justice. These tests are cheap and easy to produce. The WHO should realize that they are excluding millions of HIV-positive patients with their strict guidelines or recommendations. This thus also discourages donor organizations from producing and supplying these tests to those that need it most. The Deputy Executive Manager for Programs at the Treatment Action Group, an organization based in New York City, says that the WHO is really giving mixed signals to countries, to suppliers, and manufacturers, because they're basically saying that on one hand, we are asking for this point-of-care test. We want to do more to stop mortality. And on the other hand, actually, we think even though we have this tool, it's not worth rolling out. Therefore, the WHO and important donor organizations should increase their humanitarian efforts by providing these cheap $3.50 tests to the most vulnerable HIV-positive populations at risk of tuberculosis.